Hi, this is Nicole Kupchik, and I'm here with 10-Minute Tidbits. Today we're in Miami, Florida, and I'm with Dr. Kees Polderman. Hi, Dr. Polderman, how are you?
I'm doing pretty well. Like you said, we're in Miami.
We're in Miami.
It's sunny,
and it's Friday.
And the meeting is over.
The meeting's over. Although it's not going to be Friday when you guys are listening to this, but it's been a fascinating conference the past 2 days. So first of all, do you mind telling them a little bit about yourself? Because you've had an amazing career.
In summary, I'm a Dutch intensivist. I worked in the Netherlands much of my working life and moved to the US 9 years ago. I'm a critical care physician, and my hobby is neurointensive care, and my research hobby is therapeutic cooling, some other stuff. And the meeting today was about temperature management.
Yeah, and I have to say, because I've been involved with TTM kind of since 2002 when the studies came out from Harborview, and I think I met you pretty early on, and you've written some amazing papers. I think you've written some really helpful papers about just the physiological effects of targeted temperature management that a lot of us were trying to figure out, right?
Well, thank you for those kind words. That
it was
the
helpful,
intention.
just so you guys all know. So, yeah, but one of the things I want to chat about, so Dr. Polderman was, you led a debate between like 32 to 34, or should we go to 36, or 37.8, which is the new study. It's called TTM2. That's currently enrolling patients.
Right.
And so I thought it was fascinating. So what he did was he's like, all right, we talked about all the data and talked about what we're all doing, and then you're like, okay, all of you out there, who, if you had a cardiac arrest, what would you want?
Yep.
And what did the audience say?
I think they were pretty much into being cooled still to 32, 33.
Yeah, so the whole, I mean, it was like almost the entire audience said, if I have an arrest, take me down to 32 to 33 degrees, and I think there were only 3 people that said 36.
And one of them was my opponent.
And one of them was your opponent.
Yeah.
So, yeah.
But there were 2 people in the audience. I think one works for him.
One works for him. So if he said no, he'd get in trouble or something.
Yeah. Right.
But it was fascinating to see that many people say, if I have an arrest, take me down to 32 to 33.
Yeah.
But yet, here we are, we're studying 36, and we're studying 37.8.
Yeah.
So what are your thoughts on this?
I really think it's a bad idea. I really, with all my heart, believe that people with a anoxic injury to the brain should be cooled to 32, 33 for at least 24 hours, and maybe longer. And some evidence suggesting that it should be longer. And just going and taking away the intensity of temperature management is exactly the wrong way to go.
Yeah.
But there's debate about that, and that's why we had the pro-con today.
Yeah, and it was fascinating. But just so you all know, there's a study that's enrolling patients in Europe. There's one U.S. site, I believe, right?
Yeah, no, there's going to be several.
Several?
I mean, at this moment, there's one U.S. site.
Okay, but there might be more.
Yeah.
Where
they just started. They have 8 sites working, and they want to go to 50, I think.
50 sites?
Yeah. That's their aim.
That's their goal. But they're comparing 33 degrees versus 37.8, which is basically fever suppression.
Yeah.
What are your concerns about it?
I think the evidence for using hypothermia after cardiac arrest is solid, and I think fever suppression is beneficial, but it's less beneficial than using therapeutic hypothermia. The authors previously did a study comparing 33 to 36, and they found that the effects were the same. 33 was not better, 36 was not better, they were identical. But I think that study was flawed in the sense that they had emergency room physicians pre-screen for which patients should be in the study.
Okay.
And the standard of care at the time was 32 to 34, so every hospital was doing that.
Yeah.
Which means that if a patient was enrolled in the study, they would either get the standard treatment or not. They would have a higher temperature. So there's a risk of selection bias there.
Yeah.
But even more important than that, it took them up to 4 hours to randomize patients, and it took them up to 10 hours, average 10 hours, to get to target temperature of 33. And I think if you take that long, you're at high risk of losing your therapeutic window. And I think that's what happened in that study.
Yeah, and what did you think about the rewarm rates? Because I'll never forget looking at that graph, just seeing that the average rewarm rate was about 6 hours.
Yeah.
Did that cause concern for you,
or
what did you think?
Yeah, that caused a lot of concern because we know it's not been studied in cardiac arrest, but we know in other situations that rapid rewarming can re-trigger the injury process and you can lose some or all of the benefits of therapeutic cooling. So even if they hadn't missed the therapeutic window with the 10 hours, this rapid rewarming might have caused additional damage. And that only happened, of course, in the 33 group, because the 36 group has no room up. They rewarmed 1 degree.
Yeah.
But the 33 degree group, if rewarmed that fast, could suffer from that.
It could have negated a lot of the benefits, maybe. Yeah.
And there's no reason for it. There's no reason for such a rapid rewarming rate. Now, I can't prove that it's not okay to rewarm rapidly because it's not being studied in cardiac arrest. But like everybody who works in this field agrees that slow rewarming is safer, and there's no advantage for fast rewarming.
Yeah. Fascinating. Okay, now you talked about just a fabulous idea. So you kind of talked about the idea of considering to cool ARDS patients.
Yes.
Tell me your thoughts on that. I love that.
Yeah, this is not my idea.
Okay, but an idea you presented. Okay.
Because several people have published case reports, and there's a lot of animal studies. So if you look at ARDS, if we take a step back, the mechanism underlying it, it's vascular leakage, it's neutrophil infiltration, pro-inflammatory response in the lungs, and those things are inhibited by hypothermia. So it makes sense that hypothermia would be beneficial. Animal studies, there are like 40 animal studies that actually show that in different animal models. It's been done anecdotally in cases, and I've done it myself, just when I thought a patient would benefit from it, sometimes in cardiac arrest patients, but also in other indications. And I have the impression that it works, so I think we need to do a clinical trial.
Yeah, I think. Yeah, so, do you have any takers on it? Because you asked that at the meeting. You're like, does anyone want to collaborate?
Yeah, I invited people to mail me. I've got 4 responses so far.
All right.
And I hope there will be more. So hopefully this meeting will produce an ARDS hypothermia trial. So I'll call it CARDS.
I love it. CARDS is kind of fabulous.
Right.
I love it. So
cooling for ARDS. Yeah.
I love it. Cooling for ARDS. Do it. Wouldn't it be fun to name a trial?
Yeah.
You probably have.
You need a catchy acronym. So.
Absolutely, you need a catchy. I love it. So anyway, all right. Well, this is Nicole Kupchik, and I'm here with Dr. Kees Polderman, and we're chilling at the beach in Miami. But this is 10-minute tidbits.
So join us next year for chilling at the beach.
Next year, we'll definitely talk again at the pool.
Okay.
Again.
It's a deal.
All right, it's a deal.
Yeah.
Game on. But he has to buy drinks, just so we all know.
Okay.
All right. Thanks.